Good evening to all. I think Ampok has been consistently keeping this monthly case presentation, and a lot of us, not just residents and trainees, even consultants, have got some benefit out of it. A lot of the case presentations, including the atypical cases or the more rare cases, have been kept in this forum, and generally the approach has been how it be towards exam, and hence gives postgraduates, you know, in- uh, idea of what to expect during the exam time. Today, we have with us Dr. George, uh, assistant professor from RCC, and we have Dr. myself also as the examiner. Dr. Ketan is joining us from Indore. Um, we can start the proceedings, Ketan. Over to you.
Okay, sir. My slides are visible, sir?
Yes, your slides are visible and it's in presentation mode. Go ahead.
Okay, sir. Good evening to all respected faculties. It's been an honor to present here on this platform. Today, I'm going to present a case on lymphoma. My 24-year-old male patient, a resident of Vidisha, Madhya Pradesh, presented to us with the chief complaint of throat pain since 3 months, difficulty in swallowing since 1 month, and difficulty in speech since 15 days. On history of presenting illness, patient was apparently all right 3 months back. Then he developed pain in throat region, which was insidious in onset, dull in nature, non-radiating, not associated with any movements, and related with the medication. So patient has consulted local clinic after 15 days where he found to have swelling over both tonsillar area. And patient had taken symptomatic treatment, which according to the patient has included the antibiotics. And since last 1 month, patient developed sudden increase in the size of swelling over both the tonsillar area, which caused the odynophagia with the solid food, which progressed to cause with the liquid flow also. And there is no ulceration or discharge. Patient develops low-grade fever without chills and rigors since 1 month with no specific patterns and which relate with the antipyretics. And patient also
I would
developed
like to interrupt you at this point. Can
Yes,
you
sir.
tell me the differentials of odynophagia in a 24-year-old male?
Sir, first is if I'll think on the malignancy line, the lymphoproliferative disorders causing involving the Waldeyer's link, and also uh, uh, malignancy, sir. I'll not think about that. Other malignancy.
Do you think lymphomas are the most common cause of odynophagia in this age?
Sir, in this age, yes, we can. Yes, sir. Lymphoma is the most common cause.
Could it be oropharyngeal squamous cell carcinoma?
Sir, no, sir. Nasopharyngeal carcinoma can be a possibility.
So that brings down the question of what are the commonest cancers according to the Globocan 2000 latest Globocan data in India in males.
Oh, site specific or overall, sir?
Overall, in males.
Most common, sir, lung cancer. First is lung cancer. Then second is, sir, head and neck cancer in India. Third is, sir, this no NHL, lymphoproliferative disorders.
I would request the audience not to answer in the chat thing. They can put questions. Please do not give answers on the chat forum. Okay, go ahead, Ketan. So very specifically to India is what Dr. George is asking.
Sir, head and neck cancer, sir. Head and neck malignancies are more common.
Continue your presentation.
A patient also developed muffled voice since last 15 days. So in negative history, there is no history of any other lesion in the oral cavity, no history of any swelling in the neck region, no history of cough with expectoration, running nose, dyspnea, no history of weight loss, loss of appetite, drenching night sweats, no history of facial asymmetry, facial puffiness, no history of post-discharge bleeding, ulceration over tonsillar area, no history of abdominal distension, pain and scrotal swelling, no history of other swelling anywhere else in the body, no history of headache, convulsion, bony pains, no history of joint pain, stiffness, and rash.
Okay.
In
Can you just elucidate the role of temporality or chronicity in the history? You told certain duration for certain positive complaints. So what is the role of temporality in the diagnosis of lymphomas? What
Sir,
are the types
usually,
of lymphoma presentations based on the chronicity?
Sir, aggressive lymphoma usually have acute presentations, and indolent lymphoma usually have chronic complaints. Sir, usually lymphomas presented in a means my case point of view, it has to be unilateral presentations, unilateral presentations, and
What if there is a slow history of 5 to 6 months, but a rapid?
okay. Sir, that can be a low-grade lymphomas that is transferred into histologically that was transferred to aggressive lymphomas. That can be
And,
one possibility.
and what could be the temporality of a Burkitt's lymphoma? What is the point in history which is probably against the diagnosis of Burkitt's?
Sir, first is the acuteness of the disease, and symptom wise, sir, these constitutional symptoms are has to be there.
But your main point is
Burkitt
missing.
lymphoma.
Do you think Burkitt will last for 3 months before presentation
No,
to you?
sir. No, sir. No.
Yeah. So what is the main point there?
Duration of the presentation, sir. And
Yes. If Burkitt has to present, it has to present less than a month to you, or else it won't present to you.
yes, sir.
Okay. Continue.
History wise
past history-
also, what are the common sites for if you're suspecting Burkitt's? Any reason for you to suspect Burkitt's with your history or any other etiology in the
only
past?
sir, in my case, only thing is that this Valdeir's link is a ring is involved. So that is the only possibility. But still, other constitutional symptoms are not there. So it's a lower
History
probability
wise,
of
what are
Burkitt.
the usually common symptoms or, with your history alone, what are the common symptoms or of Burkitt's if you're suspecting Burkitt's? How common is involvement presenting with odynophagia? Can happen. It's not that it is. And as Dr. George mentioned, there'll be, as you mentioned, very, very much more shorter history than this. Very acute it will be. But
Yes,
usually,
sir.
what are the symptoms that we see? So
Sir,
that is where the
the
negative history
one is
comes
the B
into play,
symptoms.
probably.
B symptoms is there, sir. Then fatigue is there. Pruritus has to be there.
Majority of the diseases generally this thing abdominal, visceral nature, right? So a lot of them do have abdominal symptoms. That is
abdominal.
probably not. So we can
Yes.
keep it lower down in your mind.
So what are
Okay.
the symptoms of extranodal disease in aggressive lymphomas?
Sir, if it is involving the bony disease, then can be presented with the bone marrow involvement and having bicytopenias. Also, sir, CNS involvement is there, then can present it with the seizures and headache and and
Other sites, accordingly, you have
other
covered.
sites, kidney and adrenal can also cause. I mean, if the kidney is involved, then acute renal insufficiency can be there. Others are testicular swellings can also happen.
Some of the high-grade lymphomas are associated with diffusions, pleural, pericardial, etc. So symptoms of that can be there.
Yes, sir.
So even
What
that,
are the manifestations of mediastinal lymphadenopathy?
Sir, that patient can present with cough, dyspnea, cough, dyspnea, and even in some cases hemoptysis also present, and the adenopathy, mediastinal adenopathy causing pulmonary hemorrhage also, and SVC is the one of the also important presentation.
Yes.
In your history, you mentioned about B symptoms in your slide as a negative.
Yes, sir.
What is
Yes,
the
sir.
definition of B symptom and what is the significance of that? I want the incidence of B symptoms in DLBC.
Sir, B symptoms definition, sir, one is fever that is greater than 38 degrees Celsius, that is unexplained, and unexplained unintentional weight loss of more than 10% from in last 6 months, and drenching night sweats. Usually, sir, in NHL, 30 to 40% patients presented with the B symptoms, and in Hodgkin lymphoma, that is around 20% of patient presented with B symptoms.
Okay. What are the clinical points based on the history? How do you differentiate between Hodgkin's lymphoma and non-Hodgkin's lymphoma based on your history?
Sir, history, first is in Hodgkin lymphoma, the involvement of the nodal is the contiguous involvement. In non-Hodgkin, it is non-contiguous. The age of the patients, usually, sir, NHL is presented in the older age, but Hodgkin's has bimodal age presentation. And sir, vessel disease involvement is more common in NHL than HL.
What would be the
Vessel-
difference if there is a mediastinal mass which is due to Hodgkin's and which is due to non-Hodgkin's? Is there any difference in the presentation?
Presentation wise, non-Hodgkin's with mediastinal involvement can be aggressive, and patient may present earlier with the complaint of dyspnea and chest pain compared to Hodgkin lymphoma. And
Okay,
also,
the SVC higher for SVCO symptoms are higher in aggressive NHL when compared to Hodgkin's for a
yes, sir.
mediastinal. Okay.
Yeah, go ahead. Complete rest of your history.
Sir, past history, there is no similar illness in the past and no issue of TB, HIV, hospital admissions, surgery, or blood transfusions. There is no significant family history, and personal history: mixed diet, regular boil bladder habits, adequate sleep, no drug allergy. Patient is unmarried. There is no addiction history. So, in summary, my patient, a 24-year-old male non-smoker student with no significant past personal and family history, presented with swelling over bilateral tonsil area since 3 months. Size of which suddenly increased, causing odonophagia to solid food followed by liquids, with low-grade fever and muffled voice, which is not relieved by the conservative management. So I would like to examine for the further clinical things.
At the end of history, what are your differentials?
Sir, at this age, this patient is 24-year-old. I would like to think about a benign disease in which infections of bacterial or viral origin. Bacterial may be TB. Viral can be infectious mononucleosis. Also, sir, any inflammatory disease or a rheumatological disease can be a possibility. Like um, and in malignancy point of view, sir, lymphoproliferative disorders is one of the differential.
why not? What other disease would you think of? Maybe lower down in the differential diagnosis, but what other disease can you possibly think of in a 24-year-old? Not related. We are, let us have a little bias in a lot of our, for forming the DD, we can have some amount of bias as probably the patient has done some workup and then presented to us. So with the malignancy in mind, other than lymphoproliferative disorders, what other differentials would you keep?
Sir, from malignancy point of view, say, squamous cell origin DD is less likely. But yes, nasopharyngeal carcinoma can be a possibility with extension in extension towards the tonsillar area.
Yes, but the negative history, of course, I mean, negative history would be, you're going to have the upper airway symptoms prior to having all the muffled voice and odynophagia. More than that, is there anything else outside of carcinoma? Similar thing. It may need not be always oropharyngeal also.
Sir, maybe, sir, any glandular on and this salivary glands.
No, probably what I mean, respiratory symptoms should be there. What I wanted to keep in mind is probably an, fast growing mediastinal GCT or something, GCT in mind. Again, some sarcomas, very rare at this age group, probably much lower in the DD. Can that be also
Yes.
a presentation? It can be. But usually you will have other clinical features, especially external swelling and all that. Sarcomas,
Yes,
when
sir.
we are talking about, probably we have to start thinking about some PNET or even a RMS. Age is probably the only thing that is against it.
Yes, sir.
George, anything in history?
Sorry, sir.
I think we can proceed to the examination now. I think DDs are covered, I think, so far.
So after taking verbal consent from patient, I have examined the patient in proper light and sitting position. Patient is conscious, cooperative, moderately build and nourished, and well-oriented to time, place, and person. The ECOG performance status is 1. Height is 159 centimeter. Weight is 53 kilogram. BSA is 1.53 kilogram
Could
per
you
meter square.
define ECOG performance status 1?
Sir, 1 is restricted physical strenuous activity, but patient is able to carry out all the light and office work type of office work.
I want definition.
ECOG PS1.
Yes.
Hello. Sir, patient is able to only restricted physical strenuous activity, able to carry out work of a light or sedentary work, nature.
Not complete. You look into that. Okay. The proper definition. Okay. And could you define ECOG PS0?
Because PS0 is, sir, patient is fully active, able to carry out all the pre-disease activities without any restriction.
Okay, continue.
There is no pallor, icterus, pedal edema, cyanosis, clubbing. There is no generalized lymphadenopathy, skin and thyroid normal.
What's the significance of cyanosis in your history? Please don't add unnecessary things. Your presentation has to be to the point. This is not MD exam. This is DM exam. So
yes,
whatever that is relevant to the case, you present. Okay.
Yes, sir.
What is the definition of generalized lymphadenopathy?
Sir, 2 or more than 2 non-contiguous lymph nodes are involved, and there is enlargement.
What is the size criteria for deciding which lymph node is pathological and which is normal?
Sir, resist and resist one is used.
We are at clinical examination.
Sorry. Yes, in general examination for supraclavicular, it is more than more than 1 centimeter. Axillary, it is 1.5, more than 1.5 centimeter, and for inguinal node, it is more than 2 centimeter.
What is the size for epitrochlear node?
More than 0.5 centimeter.
Okay.
Sir, vitals, heart rate 76 per minute, blood pressure is 122 by 76 millimeter of mercury in right radial artery in supine position. The aspiration normal. Patient is ephemeral. On a local examination, inspection of the oral cavity, adequate mouth opening with proper oral hygiene, position of the teeth are normal, movements of tongue is normal in all direction, no lesions in oral cavity, and there is no gum hypertrophy. Inspection of the oropharynx, there is enlarged tonsillar area bilaterally reaching at midline, that is grade 4, no redness, ulceration, discharge, bleeding present over tonsils. Posterior pharyngeal wall appears normal, there is no redness. Uvula not properly visualized. Inspection of the nasal cavity and ear canal is normal.
What is
Inspection
the
of
lymphatic supply of the tonsil?
Sir, sorry, I don't have that idea.
It's level 2B, jugulodigastric. Okay.
Okay, sir. Inspection of neck, skin over neck appears normal. There is no visible swelling, pulsation, distension over neck area, and movement in all direction possible without difficulty. Then after I will proceed with the palpation. With gloved finger, tonsillar mass were felt hard in consistency. There is no pus discharge or bleeding present, which done with the edge of the tongue depressor. There is no tenderness over tonsillar area and pillars, no membrane present. Palpation of the base of the tongue, there is no positive finding. And palpation of cervical, axillary, inguinal nodal area, there is no positive findings.
Tell me, is there any with regard to the classical teaching, what is the node consistency in a Hodgkin's lymphoma, in a non-Hodgkin's lymphoma, and a squamous cell carcinoma?
So on Hodgkin, it is a rubbery consistency is there, and in the in the non-Hodgkin, it is non-Hodgkin and squamous cell hard consistency is there.
Non-Hodgkin's can be firm, and in a squamous cell carcinoma or adenocarcinoma metastasis, it can be hard. Okay.
Okay. For abdomen examination, there is a soft tender, and umbilicus is central. Liver spleen non-palpable. There is no ascites, no testicular swelling, and DRE no mass felt. RS, CVS, and CNS examinations are normal. So,
were you expecting to get a palpable liver in this patient with your DDs in mind? With your oncological DDs in mind, were you expecting to see a spleen or liver in this patient? There's a reason you specifically mentioned it, but with your DDs in mind, were you expecting it?
Sir, yes, I expected, but in this patient, it was not.
We are thinking of some probably an aggressive variant if we are thinking of lymphoma rather than indolent variant. So less likely like
Yes, sir.
hepatosplenomegaly will be present.
Yes,
Usually
sir.
seen in the indolent variant. Of course, you have some specific subtypes like hepatosplenic T cell and all that where you may get, but still in indolent variant only you have the time, and it is not due to the lymphomatous infiltration alone. So less likely
Yes.
he would develop it.
Okay, sir.
Okay. You can summarize.
So my patient, a 24-year-old male non-smoker student with no significant past personal and family history, presented with swelling over bilateral tonsillar area since 3 months, with sudden increase in the size of swelling causing odynophagia to solid food with on and off low-grade fever, with muffled voice, which is not relieved by the conservative medication, and on examination there is grade 4 tonsillar enlargement. with no pus discharge, ulceration, no cervical nodal swelling, and no hepatospinal with no systemic examination findings.
So what are your differentials at this point after history and exam?
Sir, after history and examination, one of the thing that is still tuberculosis is the and lymphoproliferative disorders, both 2DD, because infectious mononuclease I have ruled out because patient is not having this hepatosplenomegaly, and fever spike are not that high. And patient swelling has not responded since 3 or 4 months with conservative medications. So
You told the diagnosis as tuberculosis, huh?
yes, sir, possibility.
I don't agree with that. At this point, I think you should consider malignancy as the first differential. And with considering our subject and the exam of medical oncology, you should put malignancy as your first differential, most likely lymphoma, non-Hodgkin's lymphoma of the tonsil.
Okay, sir. Okay, sir.
If you are considering with just your history alone, again, lymphoma as the differential diagnosis, what is the possible with your examination and history and examination? What are the possible DDs? Can you further, subtype it? Can your history and examination help you arrive at a possible subtype?
Yes, sir. As this patient is having involvement of the extra Waldeyer's link, that is an extra lymphatic organ site, my probable diagnosis is going toward the non-Hodgkin's. And in non-Hodgkin's, yes, the presentation is of 3 months still. I'll think of DLBCL, and DLBCL is one of the possibility, and other is high grade B cell lymphoma, is one of the possibility.
What are the subtypes of non-Hodgkin's lymphoma based on the decreasing order of prevalence?
Sir, DLBCL, then follicular lymphoma, then mantle cell lymphoma, marginal cell lymphoma, Burkitt lymphoma in adults, for all these in all adults.
What is the incidence of DLBCL among NHL? What is the percentage?
Around 30%
Okay.
of all patients.
How are you going to evaluate this patient? I think you have mentioned the differentials. Now, how are you going to evaluate?
Sir, I will do the baseline investigation, which include the complete background with the differentials, with the peripheral smear, and ESR, then complete metabolic panel, which include the liver function test and all the electrolytes in electrolytes, and also the viral markers, and serum LDH and coagulation profile. And these are from the blood investigation, and other I'll send the throat swab also initially.
What are you specifically looking for in your hemogram? And when you're talking, probably at this point, you can be a little more specific about viral markers. When you say viral markers, you can probably expand and not wait for us to ask what are the viral markers you're going to send for.
Viral markers are including hepatitis B, HBsAg, HCV, and HIV I'll send. And in CB and complete blood count, I'm expecting high NC ratio, and probably any atypical cells are there.
Okay.
What do you think is the most...
Cytopenias common with your differential diagnosis? Are you expecting cytopenias?
In these patients, I'm not expecting the cytopenias to be there. But yes, cytopenias can present in NHL.
Again, it's more seen in indolent variants. Probably with this acute history, there may not enough time for, even if there's marrow involvement, to develop cytopenia if it's a high-grade lymphoma. Okay.
Yes, sir.
What do you
Judge?
think is the etiology which has led to this problem which your patient is facing?
Sir, most probably, sir, the genetic translocations in this patient, because the patient had no any history of infections or
Etiology again. Etiology.
yeah, sir, viral infections, मतलब viral etiology is still one of the possibilities.
Be
What
specific.
viral etiology?
Sorry, sir. Viral, sir, Epstein-Barr virus, Epstein-Barr virus, and then, sir, HIV positivity. And other bacterial infections are also like chlamydia, sir, and then Borrelia.
How common is
Then
chlamydia? How common does
no,
chlamydia cause lymphoma? Which is a more, what are
less
the
than 1%.
bacteria and bacteria associated with the lymphogenesis, and what other viruses are associated with lymphomas?
Sir,
Which
in
should be more
viruses, in Epstein-Barr virus, there is Epstein-Barr virus, HIV associated lymphomas, then HTLV1
common?
and HHV8 that is causing primary effusion lymphoma, and bacteria, sir, hepatitis, chlamydia that is causing the ocular extramarginal zone lymphoma, then Borrelia that is also causing the
What
extramarginal
is the
lymphoma.
common in lymphomas? Just Tiger, in lymphoma, which is the most common bacteria causing leading to lymphoma? What is maltoma?
Okay, that is sir H. pylori causing the extranodal
Congenital
lymphoma.
lymphoma, H. pylori. Yeah.
Yeah, and sir, in viral also hepatitis C causing splenic marginal lymphoma.
Etiology could in this age group, you probably are thinking of some maybe
Um,
not diagnosed yet. Some viral etiology can be a possibility. That's what sir is asking, right?
yes, sir.
So you haven't yet reached regarding the histopathological confirmation. You are told about the laboratory
Ye-
investigation. How are you
Yes, sir.
going to confirm the diagnosis now?
Yes, sir. In this patient, I'll take the biopsy, conidal biopsy from the this lymph node enlargement. Because I don't know the extension of the disease, so I'll not go the no not go will proceed with the tonsillectomy or tonsillectomy.
You
And
told there is no cervical node swelling. That's what written in the slide. Which
yes, sir,
node you
but at the local site, I don't know the extension, sir.
So how will you, so what next?
I'll,
What in a logical sequence in your OPD, this patient has come, you have to order the set of investigations. From exam point of view, you're going to tell that I would do the basic workup, I would do this diagnostic workup, I would do next stage in board. How would you logically proceed next? You will take the
sir,
biopsy.
yes.
What are we generally keep in mind? What you are practicing will be actually what is the answer we are looking for. You don't need to go in a step by step textbook answer for this. What do you do generally? What do we all do?
Sir, after baseline investigation, I'll also do the digital chest X-ray and the USG of the. I'll do the USG neck. We'll proceed with that to see any other swelling or any other things in the neck, and I'll proceed with the FNAC or biopsy, FNAC plus biopsy from the these enlarged area.
So your clinical practice in a suspect. Now we have narrowed down to one DD, that is a lymphoma, NHL probably. In your practice, you go ahead with the biopsy uh, first, and you're going to
Yes, sir.
take a true cut biopsy from the tonsil. Technically,
Yes.
how easy is that? How feasible is that?
Uh, sir, I think it's a feasible to take biopsy from tonsil
Is it called
area.
a true cut biopsy, or is it just excision biopsy, which your head and neck surgeon does? So before that, is there, so what would we do before
So
that?
before that, I'll do the
We
complete.
get some cross-sectional imaging. You're not sure
Yes,
about
yes.
where else the disease. I'm okay to get a quick results to rule out other area involvement. You can get a USG neck and all that, but clinically you are not finding any disease. Less likely USG is going to add anything more to it.
Yes,
Probably
sir.
some form of a cross-sectional imaging.
So,
is
Yes, sir.
required, or directly you can go for biopsy and then decide on cross section? There is no answer for that, but generally we may prefer to do get a cross sectional imaging at that time. If it's urgent, we may be happy with the CT.
On CT neck, yeah. Yes, sir.
But if you are suspecting lymphoma or you're evaluating for a PEO, some of these patients present with a evaluation for a PEO, we do. What else do you ask for?
Sir, first is as you discussed this contrast neck and face I'll do, and also we'll check the endoscopy, pan endoscopy I'll do at least.
So my question to you, I'll put the question different way. Does a PET have any role in lymphoma prior to biopsy?
Yes, sir. Actually,
We are
I
strongly
should.
suspect.
Yes, sir. Because if I'll do the PET scan upfront, I can get the idea of the and the maximum sensitive area, or for the biopsy, where the maximum SUV is there. I can go with that. I can go with the biopsy of that area, and also PET will help me to do the staging upfront. Of,
What are the types of biopsies for a node?
sorry, sir.
What are the
Biopsies,
types of
different types of
biopsy?
biopsies done on a node, lymph node or a nodal organ.
Sir, one is excisional biopsy and choroidal biopsy.
One
And
more?
incisional biopsy, sir.
Yeah.
What is incisional biopsy?
Uh, uh, in incisional biopsy, sir, sir, sorry, actually, I don't have much idea of that.
What is the disadvantage of doing a core needle or probably even incisional biopsy compared to a excisional biopsy in a lymphoma?
So we'll not get idea of the complete nodal architecture and the capsular extension. I'll not get the idea, and also I need to take multiple course for a proper making the proper blocks to advise for further investigations. Then excisional
You need to
biopsy.
look at different parts of the nodes, right? The germinal part, before look at and
Germinal.
the all that. So definitely, as you mentioned, architecture. So that probably is one disadvantage of doing a true cut, or I mean, incision is reasonable, a true cut especially.
So to study the lymphoma morphologically, you need to understand the cortex and the
Yes.
Also the follicles and also the capsule. So each part
Yes,
has
sir.
to be studied in detail to understand
Yes.
what type of lymphoma it is. So that
Yes, sir.
excision biopsy is the most preferred if feasible.
Yes,
And
sir.
suppose you did a PET and you found multiple sites and multiple sites of nodes, and which site would you like to prefer to take the biopsy from if there are multiple sites in the PET scan?
Sir, the node which has the maximum SUV and which is more approximable, more easy to take the biopsy.
Why do you say that?
Because, sir, there might be a chance that patient may be having nodal involvement with SUV more than 10 in the area where it is chance to damage the surrounding area, like a mediastinal disease or some surrounded by major vessels. Then, sir, there are chances of perforation or any damage to surrounding organs while taking biopsy.
What is the role of bone marrow studies in your patient?
Sir,
Bone marrow.
yes, sir, if my patient has already been done PET CT and PET is not showing any involvement of bone marrow, then I'll not go bone marrow. Then I'll not proceed with the bone marrow biopsy. But if there is a PET, if PET is negative and if I'm expecting that or unexplained cytopenia is there, then I'll proceed with the bone marrow aspiration plus biopsy.
What is the sensitivity of PET in picking up a bone marrow disease? Is it same for all the NHLs?
No, sir. For indolent lymphomas, it is more sensitive than aggressive lymphomas.
Is it the other way around?
No,
So
sir. It
where
is
actually the role of bone marrow is still applicable in indolent lymphoma, even for a PET negative disease.
in
In
early
a
stage.
early stage
Early stage.
DLBCL, probably advanced stage DLBCL, probably you can do, you can be relatively sure. You have almost 88 or 90% specificity. And regarding
Yes, sir.
sensitivity, it is almost 99%. So if you have a uptake, you can be sure the marrow is involved. Otherwise,
Yes, sir.
in an early stage, probably when you have very minimal, that is low burden in the marrow, that is when
Good.
doing a bone marrow examination is good, because less than 10% involvement of marrow can be picked up. That may not have any SUV avidity.
Yes,
That
sir.
is the thing to put. Indolent thing, in fact, it is the specificity comes down, for the uptake, bone marrow involvement by PET. So you are advised to do marrow in these patients, even if there's no cytopenia. It's reasonable to do bone marrow study in these patients.
Yes, sir. Okay, sir.
Would you do a CSF cytology for this patient?
Yes, sir. I should go with the CSF and examination for this patient particularly.
Why is it? Can you
Sir,
justify
because
that?
the involvement of the this extranodal site is there. Walden's link. Walden's link is
ఓటీపీ కావాలి నాకు వచ్చింది పంపించి నేను పంపించాను
Cross chatter, please avoid that. Whoever is by mistake, please mute yourself. Hashim, please mute the whoever it is. Yeah, go ahead. So because
Sir,
of Walden
Walden's
link involvement, you are wanting to do CSF study.
Yes, sir.
Okay, how are you going to assess the fitness of the patient for your whatever treatment you are going to plan?
Sir, I'll check the 2D echo and 2D echo to see whether the patient is eligible for the anthracycline based chemotherapy or not, and also the renal function. Earlier investigation will tell me about the kidney and liver functions. So that's it.
Okay, you did a PET scan for this patient. You found the
Yes, sir.
disease. What in this patient? What was the report? You don't need to show the report. You can just tell what the report was. You found disease.
Sir,
where else?
yes. Sir, the disease is involving the posterior that size is around 6.9 centimeter into 3.45 centimeter, involving the left-sided tonsillar area, which extending toward the nasopharynx and also posterior pharyngeal and the base of the tongue.
Okay. Any other involvement? And what stage it would be if it is a lymphoma?
Sir, that is a continuous involvement. Says it is a stage 1E. At
Okay.
one large extranodal involvement is there. So
You went ahead and you got a head and neck team involved. They said it's reasonable to do a biopsy of the tonsil. You got a
yes, sir.
tonsillar biopsy, probably under GA. Would it have been excisional or incisional? Probably it might have been, if they were
Incision.
fearing some, bleeding, it might. So they got excisional biopsy. Your pathologist is saying there is just some lymphoproliferative disease there. You are not in a academic center at the moment. You are working in the peripheries. What do you do next? What do you ask your pathologist next? So on morphology, the pathologist says that some lymphoproliferative disorder is what I'm suspecting. That's it. What do you do next?
Sir, I'll ask them to do the HC analysis for the CD markers, which includes first T and B cell markers like CD3, CD5, CD10, CD20, CD79A, CD45, and also the CK7, CK20 I'll add, and
Coming to a resource constraint setting where you cannot order everything immediately, in the perfect world, we ask for some 10 antibodies and get a result for that, but not always. How would you proceed? So, in your mind, you are still having a differential of carcinoma. Is that why you're asking for the differential C case?
No, sir,
If that's the case,
I want to rule out actually. Still, I
yeah.
want
So,
to
you
take
can just
space.
have a pan CK marker, pan CK, and what do you do
CK40
next? Pan
LCA.
CK.
Then sir, LCA will be I will add matlab CD45. Then sir, S100 HMB Vimentin.
Okay, okay. Now it is LC positive. You know, the malignant cells are
Yes,
positive
sir.
next.
Then sir, I'll add CD3, CD5, and CD20, CD19 to show whether T and B cell origin. And
Before
For
you
this
add
kind,
these markers, what is the morphology you see in the slide? What happens to the follicles? What are you seeing? If it is, if they tell you the diagnosis is DLBCL.
in okay, in morphology, sir, actually, the follicular areas are basically infiltrated. Matlab primary or secondary follicles are infiltrated by these large B cells.
It's not just infiltration, it is disrupted. It is totally gone. The follicular architecture of the lymph node is disrupted and replaced by large cells. That is what you see in the morphology. And then when you suspect that, you add the markers and confirm the diagnosis.
Yes, sir.
So tell me the final diagnosis, including the stage. If it is, if the pathologist tells you it is DLBCL.
Means, sir, in this patient or
In this patient.
okay, sir. Sir, in this patient, actually, it is a GCB, matlab germinal center B, GCB DLBCL with positivity of CD10, CD20, BCL2, BCL6, and MUM1 negativity, and with stage 1E according to the PET scan.
What is your management?
Sir, in this patient, according to the PET scan, the patient is having non-bulky stage 1E disease. I'll explain the patient about the possible treatment options, and I'll prognosticate it about the disease and the side effect of the drugs. Before that, I
How
would
will you
like to
prognosticate? What are the
say
prognostic?
statement about it being non-bulky. Any particular reason?
sir, PET scan, it is showing the size of 6.9 centimeters.
So again, side space. So you have to take a cutoff of 7.5, right?
1.5, yes,
Is
sir.
it specific to anatomy? Is it more? Is it the definition of a bulky mediastinal disease or a bulky abdominal disease? That's 7.5. There is study. So
Sir,
there's no actually exact cutoff in DLBSL. Even some studies are there where 6 centimeters are considered bulky. For a disease like tonsil, probably I would still consider as a bulky disease because
okay,
it's more
sir.
than 6 centimeters. There is studies. I mean, it's not a standardized yet. You can stick to 7.5, but keep in mind that's more for a mediastinum and the abdomen. Okay,
Okay,
go
sir.
ahead.
Sir, I will tell the patient about the disease, disease aggressiveness, and what are the possible complications or possibility of the relapse in the future course, and also the side effects of the drugs and the cost of the treatment, and
To decide
what
on
are the
in addition to the histology, which you got DLBCL, high grade GCB DLBCL, how did you also prognosticate the patient further?
as
What
this
other
patient
factors?
is having huh?
What else helped you prognosticate the patient? That you give him exact some solid numbers. Let's say he's a student of mathematics, he wants exact numbers, statistics. How did you arrive at a particular statistics or a number to say this is going to be your overall survival at the end of 4 years, or or PFS at the end of 4 years?
Uh, Sir,
Any prognostic scoring is there?
yes,
And
sir,
does
sir.
it for
Yes,
stage
sir.
one?
Yes, sir. For stage modified international prognostication indication, according to that, this patient is having score of 1. So probable 5-year PFS is around 80 to 85% patient with the 4 cycles of R-CHOP is there.
Okay,
As,
okay. So that's also
What are-
important when you get. Then before you start treatment, if the patient is not clinically stable, do you think about something else? Some other discussion should come up before we start treatment.
yes, sir.
You've done everything else. You did your echo, you did your
Yes, sir.
viral marker, including HP core antibody. Does anything else also have to be discussed in this particular patient, in your patient right now?
Yes, sir. As this patient is young, 24-year-old and unmarried, so I would like to talk about the fertility preservation in terms of either sperm banking or semen cryopreservation.
If
I'll
he's
advise that.
clinically unfit, the discussion is moot, but you have to discuss anyway with the patient and go ahead. But please keep that in mind for both exams and practical purpose. What next? What is your next line? You got all these things done. What next? What treatment would you choose for him?
Then I will plan, sir. I will give 3 cycles of the R-CHOP-based regimen, and then we'll do the interim PET analysis. And after that, in an interim PET, if the patient is having responded or a complete response is there with the PA dual score is 1 to 3, then I'll give 1 more cycle of R-CHOP and we'll keep the patient on observation.
Is there any data about de-escalating treatment in DLBCL based on your interim PET? Hodgkin's, we have a lot of data in stage 1, stage 2. Do you have the similar thing in DLBCL? In stage 3, stage 4 Hodgkin's, you have de-escalation protocols.
No, sir.
Have anybody looked at it?
Sorry, sir.
Has any trials been done? So there
Sir,
is
yes,
probably
actually, R-CHOP, there is one trial that is a flyer study that has been discussed for whether R-CHOP 3 cycles and whether R-CHOP 6 cycles has been compared, but R-CHOP 3 is non-inferior to R-CHOP 6 in this type of patient. In this,
I think what sir was asking was like, is there any evidence for response adapted therapy in DLBCL? Is there any trial for that? Just like how in Hodgkin's we have UKRATL trial, is there any
RATL trial.
response adapted therapy trials evidence?
No, sir, that I am aware of.
You can look up. Probably that has not helped as much. That is why it is not a Sandrokas.
Okay.
There is a
It is a
trial called
negative trial. It is petal trial. Okay.
Petal trial, yes, sir. Okay, sir.
So you
And,
want to give 3 cycles, reassess, and then decide on further management.
Yes,
I'm
sir.
saying the patient received 3 cycles of R-CHOP. He is DIBL, just for discussion and for clarity, DIBL 1. What do you do next?
I'll still give 1 more cycle of R-CHOP and then sir will keep the patient on observation.
Okay. Any reason you don't want to add multimodality treatment, radiation, for example?
Sir, there is a trial of, there is a trial of adding radiation in such patients. There is no such there is no OS advantage at the end, and only in increasing the toxicity of radiation is there. So avoiding RT in such patient is beneficial for patient.
I think I will
think
add here that in flyer trial, the inclusion criteria had age-adjusted IP of 0, which means that
Yes,
if
sir.
somebody has got extranodal disease, that is not coming under the purview of flyer trial. which means that probably if you consider it as stage 1E, extranodal disease, probably 6 cycles of R-CHOP would be my suggestion, but I think it's okay.
Yes, sir.
For discussion purpose, I think it is okay, but both options are there. Individually, of course, we'll this thing. Some of us may even prefer to add radiation at the end of 4 cycles, or as Dr. George says, prefer to give 6 cycles because of the 1 knee presentation. You should be able to balance the argument. When it comes to R-CHOP, the discussion is going to be about that. Intensifying therapy, any other alternatives to R-CHOP for this patient?
Sir, R-CHOP 14 days regimen is one of the option.
But what is there any benefit? Anything the
No,
trial
sir.
has
Yeah, no OS benefit is there, sir.
more
PFS,
toxicity?
yeah, more toxicity.
How do you administer in your practice? How do you administer the rituximab first dose?
Sir, for rituximab, proper pre-medications, including the antihistaminic, antiemetic, and the in hydrocortisone dose I state, and after that paracetamol orally, and then I'll start with the rituximab in 500 ml NS at the rate of 50 milligram per hour for initial 30 minutes, and to check the patient is having any infusional reaction is there or not. And if patient is tolerating for 30 minutes, then I'll proceed with the I will increase the dose of 50 milligram per hour every 30 minutes till the 400 milligram per hour. So
you want to start slow. So a lot of protocols is a first dose, you of course infuse slowly. Practically
yes, sir.
speaking, this question has been asked in 2-3 places, including to myself during my final exam. It indicates of how you have worked in the ward also. So you can tell about the dilution part. If it is total dose comes up to 600, you dilute only 100, so that if there's anaphylaxis, you're not wasting the rest of the expensive drug. This is an old fashioned answer which I'm telling and not exam related, but then probably that will be there. And you initially start at 50 ml per hour, and then every half an hour, 1 hour and you can increase the rate of flow.
What is the definition of tumor lysis syndrome, laboratory and clinical?
Sir, tumor lysis syndrome is occurred because of the chemotherapy or aggressiveness of the disease when the tumoral lies, then the internal contents are released into the
Definition, please.
Sir, it's a syndrome which occurred because of lysis of the cell.
Please read what is laboratory and clinical TLS definition. Okay, and how are you going to manage tumor lysis syndrome? If suppose in this patient post first cycle, he comes back to you with clinical tumor lysis.
Okay, sir, I'll try to hydrate the patient. Adequate hydration with the urine output of more than 100 ml per hour should be there, and I'll give this xanthan oxidase inhibitor, and we'll see the patient is having any other clinical symptoms or there or not, and according to that I'll proceed for other raspberry cases needed or not.
Anything to help you assess whether the patient has risk for TLS?
Sir, first is, sir, whether the patient is having upfront WBC and symptoms, then bone marrow involvement is there or not, and the type of histology and the pre-treatment uric acid levels. That can tell me whether the patient will develop the TLS or not.
Disease burden, and as you mentioned, uric acid levels. So even based on that, you can even think about prophylaxis with raspberry case.
Okay, sir.
How will you evaluate this patient when they come for each chemo cycle? What all will you look clinically in this patient? And when he comes for cycle 2?
Sir, I will see the complete blood count report to see the complete blood
Clinical
count. Okay. Clinically, sir, patient symptoms, symptoms, how much the symptoms are relieved. Is there any side effect of the drugs? Patient and is there any episodes of fever or other
What will you
symptoms?
specifically look for side effects for a patient on RCHOP?
Sir, first is whether patient is develop any peripheral neuropathy, when patient is having any the uh, f- fever after getting discharged or within 5 to 7 days, or then any uh, this hematology, sorry, any dysuria or hematuria is there or not.
What is primary progressive lymphoma?
Sorry, sir, no idea of that.
Okay, then what is the current status of current evidence of dose adjusted RIPOC for DLBCL?
Current sorry, sir, I didn't get the
evidence as far as the indications of dose adjusted RIPOC is concerned for DLBCL.
Dose suggest ARIPOC, or and also do you have something to say where it is beneficial, or is it beneficial? That is simple as that.
In a poor ventricular function patients, we usually go with the dose adjusted epoch.
Dose suggested epoch has a continuous infusion of anthracycline.
Yes.
So now you brought this question up. Let's say this boy has a heart dysfunction. Okay, to answer your first question, there is probably no survival benefit when you compare RCHOP and dose adjusted epoch.
Yes, sir. RCHOP and DARPOC, sir, tolerability is more with the RCHOP, and the side effects are more with the DIPOC still.
So the second question, now that you brought it up, let's say this for the academic discussion, this patient has cardiac dysfunction. You have ejection fraction of 45, probably something childhood. How would you then manage it?
Sir, in this, then I'll go with the avoiding the anthracycline or the liposomal doxorubicin based regimen like RCDOP or RCEPP.
Okay. And if that is not possible, everybody may not be able to afford liposomal doxorubicin. So you can
Then,
completely
sir,
eliminate cyclin if the EF is
less than
between
30%.
30 and 50, probably you can even consider mini RCHOP. Do you know what's
Yes,
the
sir.
dose and of anthracycline? And is there anything else that is reduced?
Sorry, sir.
Do you know the doses in mini RCHOP compared to conventional RCHOP?
Sir, 50% dose reduction is there with the CHOP regimen, but the rituximab dose is same.
Okay. Cyclophosphamide is around 400 and that just 50%.
Okay. With regard to the intensification of treatment, what is the current evidence and indications of polatuzumab vedotin?
Sir, polatuzumab vedotin is being tried in that where the state modified IPI is more than or equal to 2, and in the patient of stage 3 to 4 or stage 2 with extensive mesenteric disease, that has been given with the that is polatuzumab with CHP and compared with the RCHOP. And it has been seen that around at 28 month analysis, there is a PFS of more than PFS is 77% compared to 70% in a RCHOP group, but there is no OS benefit. So yes, polatuzumab we still can add.
Listen to what you told, which is a particular subgroup that benefited. That
Yes.
particular patient population had 1/3 of the patients of that particular subgroup. Your non-germinal center patients.
Yes, sir.
On these patients, we can consider. And preferably stage 3, stage 4, not for a 1E probably.
Yes, sir.
How will you assess with the end of treatment, completion of treatment? How are you going to evaluate this patient?
So end of treatment, I'll do PET scan after at least 4 weeks of the of treatment to see the response. And according to that, I'll plan for the further treatment. If the patient is developing in my sir, in overall, should I tell or for this particular patient?
For this patient.
Okay, so if patient has completed the treatment and if I've kept the patient on observation, then I'll examine the patient or history and physical examination and other laboratory investigation. I'll do at least every 3 to 6 monthly for 5 years. And for the say and this radiological examination, I'll do at least every 6 monthly for first initial 2 years.
What are the long-term capacities of
negative of treatment? What would be your 6 monthly cross-sectional image of choice? What is the practice?
Sir, generally in practice, sir, majority of patients are able to do the CT scan only. But in this patient, if I had done PET scan upfront, then I'll proceed with the PET scan only. And only if the isolated bone involvement is there, then I'll proceed with the PET scan only.
Patient in your patient is PET negative. This particular 1E patient is PET negative. You don't have any additional indication or benefit of doing a PET in your routine follow-up. When he's asymptomatic, comes for a routine follow-up after 6 months or 1 year. So a CT scan with contrast should be enough. That would be
Yes,
the
sir.
answer. George,
Suppose
if there's any more
patient is,
questions,
suppose your patient is anxious and wants ask you whether
Hello?
is any maintenance can
Sir,
be given.
can you please, sir, can you please repeat?
Suppose the patient is anxious and asks you whether can I take any medicines post CR? What will you suggest to him? Is there any role of maintenance in DLBCL? That's my question.
Yes, sir. There is a role of rituximab maintenance every rituximab, that is 375 milligram per meter square every 8 weekly for up to 2 years is there.
Are you sure?
Yes, sir.
DLBCL, please keep in mind, Ketan, DLBCL.
Oh no,
If you
no,
think
sorry, sir. That is in the indolent lymphomas. Yes, sir. Yes, sir. No maintenance, sir.
There has been trials of the
lenalidomide and rituximab, both are negative studies. Okay, so no role of maintenance.
Yes, sir.
What about consolidation in that case? High-grade lymphoma, is there any rule for consolidation with the autologous stem cell transplant?
Yes, sir. Consolidation. No, sir. Not in consolidation. If the relapse is in the relapse,
Yes.
I'll go
In the
consolidation.
DLBCL, consolidation has not shown any benefit, maybe even added toxicities.
Yes, sir.
And you could deal with the additional 5 to 10% treatment-related mortality in lymphomas.
Yes, sir.
If George, any last question, or shall we wind up? I think we have reached 8:30.
Yeah, just the options of treatment in relapse. One more question.
Sir, if the patient is upfront means the indication of the transplant is there, then I'll go with the second line chemotherapy, and then based on the response if the patient attend the CR, then I'll proceed with the high dose chemotherapy and autologous transplant or a CAR T cell therapy. And if the patient is not a candidate for transplant, then I'll go with the second line chemotherapy. And if the relapse is occurring in less than 6 months, then I'll directly go with the CAR T cell therapy, sir. And other options are there are sir newer bispecific T cell engagers.
Yeah. So again, first, when you start off the answer for a lapse if a question about lapse refractory DLBCL is asked, again, the time of
More
relapse
than
less
12
than,
months.
it is not a very chemosensitive. You still try to get the disease under control. Any of the regimens are, none of them are compared to each other. Anything is fine, whatever you're comfortable with, whether you use RIs or RDAP, DAP plus or minus R. And of
Yes, sir.
course, autologous may be less preferred if the patient has relapsed less than 6 months. We may prefer to give a CAR-T consolidation.
CAR-T, yes.
Uh,
Yes, sir.
And autologous obviously remains an option when they're chemosensitive as consolidation.
Yes, sir.
George, some feedback. All feedbacks are only positive. Okay, Ketan. George, feedback for Ketan. And then we'll wind up
Yeah,
the
I think
session.
your presentation was good. You presented really well. Answered also quite well. All the best.
Thank you, sir. Thank you, sir.
Okay. Ketan, little bit polishing. You got your DDs of your up to the history part. It went very smoothly actually. During some of the, you have to go back probably a little bit to the basics. Treatment, if you're reaching
Yes.
up to here, probably you're getting a high marks from your presentation. We're able to talk about trials, talk about comparison of R-CHOP and Ampok. If you reach up to there, you're going to get some good marks. But probably polish a little more of your basics, including the pathology, and not just specifically to lymphoma, in general for the pathology, and your how
Yes,
do you evaluate a little more in detail, benefit of one modality versus another, investigation versus even diagnostics versus staging, etc. Okay, well
yes, sir.
done. If
Yes, sir.
nothing else, we'll wind up the session. Thank you all for joining us. We will consistently keep these case presentations going on from Ampok's side. All the best to you,
Thank you.
Ketan.
Thank
Thank
you very
you.
much,
Thank
sir.
you.
Sí.